Hi, I'm Jeremy Richmon. I am going to be discussing TORS for the larynx and hypopharynx. I have no disclosures. So first, is there superiority of one treatment versus another for tumors of the larynx or hypopharynx? And I think most people would contend that, at least for early stage larynx cancer, radiation and surgery are essentially equivalent. There was, however, one large meta-analysis that compared primary surgery versus primary radiotherapy for early stage and did demonstrate superiority of surgery. However, in the hypopharynx, that has not been shown. There is actually a level 1 randomized controlled prospective trial, the EORTC 24891, which randomized patients between surgery versus non-surgical therapy and demonstrated equivalence. However, a superior laryngeal preservation rate with non-surgical management. So oncologically, these are essentially equivalent, but the reason that we employ surgery if and when we can is because of the functional superiority and the ability to preserve the larynx. So we're not going to be discussing open surgery, but the alternative to TORS really is transoral laser microsurgery. And what are some of the limitations of this? Well, line of sight. The use of external or rigid scopes can be very challenging. The instrumentations tend not to be articulated. They're levered instruments that can magnify one's tremor. This is oftentimes one-handed surgery with one hand controlling the laser or the microscope. And this also makes it certainly more challenging. And there is a difficulty or a discomfort with piecemeal resections and margin assessment, both from the surgical perspective and from the pathologist. And control of bleeding can be very challenging when looking down a scope with a microscope and using small instruments. So in contrast, what are the advantages of using the robot in the laryngopharynx? Well, as you know, the robot provides this immersive three-dimensional high D view with a steerable scope, meaning that you can look kind of around corners based on the scope that you're using. It really provides four-handed surgery. And in fact, with the SP model, it's five-handed surgery because you can have three effector arms as well as the two instruments that your bedside assist is using. The instruments are wristed, they're tremor-free, and they're scaled. And it allows for an in-block resection. But the disadvantages of the robot. So we're going to go through the models really here because the SI, which is the one that we're most familiar with and one that you may be training on now, uses 5mm instruments, which are great, but this platform is really at the end of its life and will be retired within the next year or two. The XI, the newer generation, has 8mm instruments, which make it a little more clunky to work in the narrow confines of the larynx or the hypopharynx. And furthermore, it's not FDA approved for head and neck surgery. The Flex robot made by Robotics is no longer supported by the company. And so that really leaves us with the SP or the single port, which is the newest platform and likely the ideal platform for surgery in this area. For those that aren't familiar with the SP, there's three effector arms and the camera, all which articulate through a narrow 2.5 centimeter single port. Because of the parallel orientation of the instrumentation, it really facilitates getting down low into the larynx and pharynx. And this is kind of a schematic illustration of that. Here we have with the SI model or the XI, trying to approach a lesion in the oropharynx, really not that challenging as these arms are triangulated to get to that area. But as we aim for targets further down in the larynx and pharynx, these arms up here have to become much more parallel, and that's where we start getting collisions and challenges with trying to get to those lower lesions. In contrast, the single port, as I mentioned, all the instruments are parallel and can reach those further, more distal areas. Which really brings us to this point, which is the most important factor for performing a successful TORS is the adequate exposure of the operative field, which ensures 3D viewing of the lesion and room for the robotic arms to move without colliding. Without this, these procedures are really very challenging. So this is one of the earliest large multi-institutional meta-analysis studies that looked at the oncologic outcomes of TORS. And it was across all sites. And so it provides us with some idea of how frequent we are doing surgery in the larynx and hypopharynx. And as you can see, out of 11 academic centers with over 400 patients, only 8% of the patients had surgery. And that's why we talk about TORS primarily for the oropharynx, and really for a very small subset of patients that we feel are appropriate surgical candidates will we employ this technique. So here's one of the larger studies out of France that looked at the outcomes of TORS for supraglottic laryngectomy. And that's really the primary area that we're operating on with TORS is the supraglottic larynx. There was 75 patients total, 42 of which were in the medial aspect of the epiglottis and 33 that were lateral, including some of the piriform sinus. And their overall oncologic outcomes really are quite good. 8% of patients required a trach, and the most common complication of this surgery, not surprisingly, was postoperative hemorrhage in a not insignificant number of patients. So there is a much larger systematic review of multiple institutions that were doing TORS for supraglottic larynx cancer. 14 patients were evaluated, including 422 patients. The mean age was 61 years old. A neck dissection was performed in 57%. Not surprisingly, we usually perform neck dissections for supraglottic cancer. This was done concurrently in 20% of patients. Up to a third of patients had trachs, and the positive margin rate was really very acceptable at 5.4%. And you can see some of the complications here in the institutions that were involved with this study. And as you can see from the T staging, the vast majority of these tumors were all T1 and T2. Again, not surprisingly, as those are the ones that are going to be most amenable to a TORS approach. This is some of the oncologic data again. Feel free to pause if you want to look through this, but again, relatively favorable. So what about the data for piriform sinus and TORS? So this is the largest study. This was the French GETEC study group, which included 8 different institutions in France that reviewed their experience with TORS for the hypopharynx or piriform sinus cancer. And again, most of their patients were early stage. This photo demonstrates likely a T2 hypopharyngeal cancer with an in-block resection via TORS. None of these patients required reconstruction. Neck dissection was performed again in the majority. A little over 50% had adjuvant therapy. Patients stayed in the hospital a mean length for 10 days. Bleeding was only 5%, trach in 12%, but really, you know, the goal of these surgeries, as I mentioned, obviously oncologic, but is that 93% were able to maintain a full oral diet, which is really excellent. There were, however, 30% of patients that had early aspiration. One thing to keep in mind, which was a bit of a surprise when looking through the data, is that clear margins were obtained in 70% of patients. 30% had positive or very close margins, and so certainly this can be faulted as a big detriment of the transoral robotic approach with a margin rate, a positive margin rate that high. And again, the oncologic results are really what you would expect for hypopharyngeal cancers, which is the worst subsite of the head and neck. So the single port is really just rolling out. We don't have a lot of data on how it performs in long-term data, that is, from the functional and oncologic standpoint. This is one of the early studies out of Korea which is really now just 2 years old. But they compared the SP to the XI, and you can see there certainly is a superior visualization of the endolarynx compared to the XI. And they found that it was quite successful to be able to do more complicated maneuvers and resections in the hypopharynx. The advantage of the SP, some of these we mentioned already, is that you can use 3 effector arms, so one to retract and then a right and left arm to manipulate. The single port allows access through a narrower mouth down lower into the upper air digestive tract. So that obviously is the big advantage of this. Furthermore, the camera has 2 joggle joints, which allows for this cobra position, which you'll be hearing a lot during your training, which can facilitate the view not only around corners, but looking up into the endolarynx and into the piriform sinus. Disadvantages, however, are these instruments are 6 millimeters as opposed to 5 millimeters for the SI, and there's no advanced energy devices such as harmonic available on the SP at this point. So what are some of the pearls of operating in the supraglottic larynx or hypopharynx? Exposure obviously is key. We usually use a FK retractor, or my preference is the flex retractor, which does have some endolaryngeal blades and really facilitates exposure there. Dental protection. So patients are going to be suspended oftentimes for a long time, just like with transoral laser microsurgery. I recommend using Aquaplast because it's very low profile and very strong to protect the teeth. So it gives you better exposure, but also better dental protection for the duration of the case. Flex mouth gag, which I just mentioned. So if you're doing a lot of oropharyngeal cancer, you know that we oftentimes are going to be ligating the lingual artery and facial artery. For supraglottic or the hypopharyngeal area, you should think about ligating the superior laryngeal vessels with or without the lingual. So trach and NG placement. So big issues when you're operating in this area, and it's going to be a case-by-case basis. The one thing I will say is that if you are doing a concurrent bilateral neck dissection, these patients are going to have significantly more dysphagia and airway edema, and you should consider doing a trach. And SLP should be involved in the care of all of these patients because, as you saw from those early results, there is going to be a significant number that have aspiration early on and will need intervention from SLP in order to facilitate a safe swallow. They should be employed before and after their surgery. So thank you very much for your attention. Hopefully this was helpful. Feel free to reach out to me by my email here. And I've also included a link to a YouTube video that I did years ago on supraglottic laryngectomy if you want to watch the technique of the surgery in detail. All right, thank you very much.